Hello, my name is Parks Remcho, and I'm an MD PhD candidate in the Coles lab at Tulane School of Medicine. I work in a lab that does a lot of vaccine development, and kind of the point of my talk today is just to give a brief introduction to vaccine development and what we're doing in the lab. I think it could have pretty big implications for different physicians all across the South. So to begin with some context and why this might be important to us in particular, uh, bacterial infections of the lung are on the rise. There is a pretty substantial difference or racial disparity in who is getting bacterial infections of the lung. And actually, they've become much more common in the South as water levels have risen and things have become even wetter down here. We're seeing a lot more bacterial lung infections. A lot of them are caused by Enterobacteriaceae, and coming up with a new vaccine that maybe uses a different mechanism is pretty important. So the lab that I'm in developed this vaccine, which we call OMP-X LTA1. It's a subunit vaccine made from the outer membrane protein of a strain of Klebsiella called C4. So that is a pretty mild mouse-adapted strain. And so there's really very low risk, even if by some fluke there was a problem in vaccine preparation. It's adjuvanted with LTA1, which people might recognize as a labile toxin from E. coli. Part of the problem is that most serotypes of Klebsiella elicit a very weak immune response. So just putting the OMP-X in there without an adjuvant, really we see very little reaction. Importantly, we get a lot of protection from this vaccine. So it's administered mucosally. We give it IT. In order to do that, we just tug on the mouse tongue and gently pipette the vaccine down to the trachea. It's a small enough volume that it's a little bit like water going down the wrong pipe. Mice actually don't cough or regurgitate, so they have very little problem with it. And they're happy and running around within a minute of the procedure. We boost them at 21 days. So much like other vaccine schedules, we just see a much stronger response. Importantly, this vaccine works differently, right? We're not giving it IV. We're not giving it like a standard vaccine. And it also works differently when it's in the body. So whereas most vaccines would elicit a pretty strong antibody response, this vaccine is generating a T cell response. And cellular immunity versus like humoral immunity is a pretty big discussion. And a discussion I think is worth having as clinicians, because 80% of an individual's immunocytes are actually sequestered within mucosal surfaces. So when we're relying on antibodies, we're really relying on a very, very small population of the immunocytes, only the B cells, and really only relying on those B cells and plasma cells that are in circulation. But if 80% of the immunocytes are in mucosal surfaces, we're going to want to leverage those more. Now, we get a specific T cell response, and we call those T cells T resident memory cells. They're resident memory cells because they're CD4 cells that are present only in the tissue where we have administered the vaccine. So in the nasal mucosa, upper airway, and down all the way into the lung, we see these populations of T cells. Importantly, we actually know more about what these T cells are. We know they happen to be a subset of T resident memory cells called Th17 cells. And they're called that because they produce a lot of IL-17. We can see that we've quantified the IL-17 alpha positive cells and show that with our vaccine, there are more, and that IL-17 alpha is produced in greater quantities in the mouse lung of a vaccinated animal. We've gone further and looked at the chromatin of those T cells, and inside the nucleus of those T cells, the chromatin is more accessible for the locus of IL-17A. So importantly, we know that we are epigenetically modifying T cells in the lung to make more IL-17A. And we know that the vaccine is protective. We know that they're making IL-17A, but we don't necessarily know what is connecting those. But we have some hypotheses. So lung structure cells like fibroblasts and bronchial epithelium are often overlooked as participants in the immune cascade. So what we wanted to do was start to look at how these cells may be playing a role in giving our vaccine efficacy. So we looked for fibroblasts that were expressing the IL-17 RC receptor. This is the main receptor in the lung for IL-17 alpha. And when knocking it out, we saw that these mice were no longer protected. Now with this hypothesis that fibroblasts are important, put lung fibroblasts in a dish, treated them with various different combinations of IL-17, TGF-beta, and saw that IL-17 really is what is eliciting a response in these lung fibroblasts. And that response is CC chemokines. This informed our hypothesis and informs us of where we're going to go next. We've hypothesized that vaccine-induced Th17 cells are epigenetically modified by vaccination. They secrete the chemokines responsible for recruiting macrophages to the lung. Those are the macrophages that respond to CC chemokines. And that they are recruited to the interstitial compartment of the lung, which is where that Enterobacter infection would normally invade. And they improve the local ability of local macrophages to clear Klebsiella pneumonia. With that, I just want to give some acknowledgements to my fellow lab mates, especially to Shamima, who is here in her hijab. She has really been instrumental in teaching me so many different techniques in the lab, especially when it comes to analyzing my sequencing data.
Alrighty, Parks, thank you so much. I do have a question.
Yeah.
So how do you kind of plan on getting around the issue of vaccine administration? So it seems like, you know, we're reaching these TL17 cells in the lungs of mice, but how are we going to reach them in humans?
For sure. So right now, we have a device that's very similar to like flu mist. Now, the particle size that comes out of one of those misters can actually be modified to target different areas of the airway. So smaller particles will mostly land on the upper airway. And when you have a little bit larger of a particle, the kind of momentum behind that is more likely to make it farther down. So I do not anticipate doing tonguefuls on humans, but probably our first human trial will be with something like that.